So welcome everyone to the Best in Class MD Long COVID webinar. We have an exciting hour planned for everyone. So we'll get the show on the road and let everyone enter the webinar. Okay, so this is our agenda today. So we're going to give an introduction to Best in Class MD. We're going to introduce our panelists. We're going to give an overview of COVID pathophysiology. And then we're going to talk about the state of long COVID, its impact on workers' compensation, and then we'll have 30 minutes for a Q&A. So as the webinar goes along, please submit your questions and we'll address those during the 30 minutes. And so many of you may be wondering, what is Best in Class MD and what is this company that's talking about long COVID today? So our mission simply is to create a front door that begins with access to expert care. Our goal is to assemble a national network of the top 1% providers. And so to do that, we need to create a facile telehealth platform that provides value to our customers and our clients. And so we would consider ourselves a healthcare disruptor. The problem was that historically, the provision of medical opinions was limited to the brick and mortar, as we're familiar with, which includes the clinics and the hospitals. And in that traditional paradigm, there were limited opportunities for care coordination and access to expert medical opinions and tapping into some of the leading minds in healthcare. And as you can imagine, that leads to a stratification and disparity in care. Well, the event was that in 2020, COVID-19 really caused a rapid adoption of digital healthcare and a disruption of the traditional brick and mortar paradigm. And what we saw was an opportunity to connect some of these leading minds to some of the providers and the specialists around the country. And that's what we did. And we started the company in May of 2020, and we've been working hard ever since to disrupt healthcare. We have a strong geographic presence. We have over 200 clinical experts, and we have diverse medical specialties that not only includes musculoskeletal, but includes various medical subspecialties. And our experts are represented in over 46 states at this point. We have two offerings. The first is the direct consumer, where you can find us and create your own portal and access a medical provider 24/7. And in that realm, we're sort of a concierge medical approach. And we have patients from across the country and people who simply are just looking for direction and looking to get a second opinion. We have a business-to-business offering where we tailor offerings to self-insured employers, workers' comp insurers, and third-party administrators. And we also take care of professional workers' unions, such as players associations and steel mine workers. How do we work with our business-to-business clients? Well, we do case reviews with our nurse case managers and claims adjusters, the goal being to make sure that the care that is provided is actually relevant, and we identify red flags. We determine medical necessity, and we can help to define causation and provide a roadmap around maximum medical improvement. And for first opinions, we can actually provide injury triage. And so, moving on to discussing our panelists here. So I have the privilege of serving as a moderator on tonight's session. And so we are joined by Drs. Lawrence Purpura and Drs. Christina Eckhart, as well as Lara Hill. Before I introduce our panelists, I'd like to do a little brief intro about myself. I'm remiss to give my background. So I'm an orthopedic surgeon, co-founder and co-CEO of Best in Class MD. I'm a sports medicine surgeon and an associate professor of orthopedic surgery at Cornell Medical School. And I started Best in Class MD out of a desire to scale the degree of impact. I wanted to transcend beyond bedside healthcare delivery and improve how we consume healthcare on a broader level as a society. Our first panelist is Dr. Lawrence Purpura. Dr. Purpura is an infectious disease physician at New York Presbyterian and an assistant professor of medicine at Columbia University. He's a leading national expert on viral pandemics. He has worked extensively with Ebola survivors in Liberia and was formerly an epidemic intelligence services officer of the Centers for Disease Control and Prevention. He's now dedicated his research interests to advocating our understanding of long COVID, and we're honored to have him as part of our webinar. Dr. Christina Eckhart, she is our second panelist, and she's an assistant professor of medicine in the Division of Pulmonary Allergy and Critical Care Medicine at Columbia. She completed fellowships in pulmonary and critical care medicine at Columbia, while also receiving a Master's of Science in Biostatistics from the Mailman School of Public Health. During the COVID-19 pandemic, she cared for patients with severe COVID-related respiratory failure and published several clinical trials that have advanced our understanding of COVID. Currently, she takes care of patients with post-COVID lung damage. We're honored to have both Dr. Eckhart and Dr. Perper as our panelists tonight and as part of our BICMD network. And our final panelist, last but certainly not least, is Lara Heal. Lara is the current Senior Director of Managed Care Services for Maine Employees Mutual Insurance Company, MEMIC. Lara is a registered nurse and certified case manager with over 22 years of case management experience with a strong focus in insurance disability. As a side note, MEMIC is ranked by Forbes as a top 30 workers' comp insurer based on market share. Lara and MEMIC have been BICMD clients for over a year and have seen us through our transition to a multi-specialty expert medical opinion vendor. In her position, Lara brings a unique perspective to our discussion tonight, and we're excited to have MEMIC as a sponsor of the webinar. All right, so I'm going to pass things off to Dr. Eckhart, and she's going to lead off our conversation tonight by talking about long COVID pathophysiology.
Thank you. Thanks for the introduction. Hi, everybody. My name is Christina Eckhart. I'm a pulmonologist at Columbia University Medical Center. And today I'll be presenting this talk entitled The Pathogenicity and Systemic Manifestations of COVID-19 Infection. These are my financial disclosures. I do receive consulting fees from BICMD as well as funding from the NIH. So as we are all well aware, coronavirus disease 2019, or COVID-19, is a highly infectious viral illness that has had a catastrophic effect worldwide. As of June 2022, there have been over 530 million confirmed cases of COVID-19 infection worldwide and over 6.3 million deaths. In the United States alone, there have been over 85 million confirmed cases and just over 1 million deaths, making this the most consequential health crisis since the influenza pandemic in 1918. So one of the reasons COVID-19 has had such a catastrophic effect is because it's a highly contagious virus. And one of the reasons for the high levels of viral transmission is the structure of the virus. The virus is transmitted through inhaling small droplets or particles that contain the virus. The virus is then exposed to the respiratory tract, where it enters host cells through interaction of its spike protein on the surface with an entry receptor called ACE2. Now, the efficiency with which the virus binds this ACE2 receptor is a key determinant of viral transmissibility. And COVID-19 has a very high affinity for the ACE2 receptor compared to other viruses, which partially explains the increased transmissibility of SARS-CoV-2. Now, once you've been exposed to the virus replicates and generates infectious symptoms through several mechanisms. First, the virus causes direct tissue damage. The virus replicates abundantly in the upper airway, and this viral replication directly damages lung tissue. Second, the entry receptor that the virus binds, the ACE2 receptor, is downregulated once the virus binds to the receptor. And that receptor is important for regulating fluid and electrolyte balance in your body. Downregulating this receptor leads to tissue injury and generates local inflammation. Third, the virus damages the cells that form the inner lining of your blood vessels, which are called endothelial cells. And this endothelial cell damage generates inflammation in the blood vessels, which increases the risk of forming small blood clots that can block blood flow in the small vessels throughout your body, leading to end organ dysfunction. And fourth, the virus alters your immune response. In severe cases, COVID-19 infection triggers your immune system and triggers an exaggerated inflammatory response, which is linked to increased tissue damage and worse prognosis. Now, COVID-19 predominantly targets the respiratory system. The early phase of viral infection is characterized by viral replication resulting in direct virus-mediated tissue damage in the lungs. In the later phase of infection, the infected host cells trigger an immune response that leads to high levels of inflammation in the body. As a result, COVID-19 can cause lung complications, including pneumonia. So here we see CT imaging of a patient with COVID-19 pneumonia. And now in a normal scan, your lungs appear black because they're filled with air. But in this scan, we can see these patchy consolidations in both lungs, which indicate sections of the lung that are filled with fluid as a result of viral infection. And this can lead to severe respiratory failure and potentially long-term damage to the lungs. Now, while the respiratory system is the principal target for the virus, it can affect other major organ systems. It can affect the neurologic system. We've all heard about loss of taste or loss of smell, which are some of the neurologic complications of viral infection, but it can also cause headaches and confusion. It can affect the cardiovascular system and has been shown to cause heart failure or abnormal heart rhythms. It can cause liver inflammation and gastrointestinal symptoms, including nausea and vomiting. And it can cause kidney damage, leading in some cases to the need for short-term dialysis. Now, acute COVID-19 infections typically last for a maximum of 4 weeks, beyond which viral replication typically resolves. However, we have witnessed the emergence of post-acute sequelae of COVID-19 infection, which are symptoms or complications that persist beyond 4 weeks after the initial onset of symptoms. This long COVID syndrome is characterized by persistent systemic symptoms, which can range from cognitive disturbances, fatigue, and generalized weakness to persistent shortness of breath and cough. And recent studies have suggested that anywhere from 20 to 50% of patients recovering from COVID-19 infection report persistent symptoms beyond 4 weeks, which makes this a really critical area for further study. And luckily, our next speaker, Dr. Lawrence Purpura, is an expert in the field who is doing just that. So with that, I'd like to say thank you, and I look forward to talking more later on in the session.
Great job, Dr. Eckhart. Really interesting stuff. And so I'm going to pass it on now to Dr. Purpura to tell us a little bit more about long COVID and to discuss some of his work in this area.
Thanks first of all, for the invitation to speak to the Best in Class MD group today. This is a topic that's very near and dear to my heart. As was mentioned, I've been working with post-viral syndromes for many years now, and initially became interested with my work with Ebola survivors in West Africa, where it became acutely evident that viral infections can cause more disruption many years down the road than we initially anticipated. And what we're seeing now with COVID is unfortunately the story that we've seen after many other viruses, Ebola included. I also am an HIV provider at NYP, and clearly we all know that the long-term effects of other viruses like HIV. So thank you, Dr. Eckert, for that introduction and overview of SARS-CoV-2. I'm going to focus a little bit more in my slides on the epidemiology that's been proposed to date, and as well as underlying mechanisms and management. So I do disclose that I partner with Regeneron on some of the long COVID immunologic testing that we're working on, including some of the preliminary data that I'll present today. So I found that one of the best ways to present long COVID is to categorize the presentations into the expected versus the unexpected. And the expected sequelae are things that we would, really are not surprised to occur after a respiratory viral infection. Unfortunately, post-intensive care syndrome is very well established, and many of us have cared for patients with this from a myriad of both infectious but also non-infectious illnesses. And in a respiratory infection such as COVID, we've seen very high rates of pulmonary fibrosis, cardiomyopathy, with both of these being due to direct cardiac injury due to the virus itself. And also, unfortunately, the tremendous mental health sequelae that we've seen that is well known to happen after ICU and critical care. It can manifest as PTSD or anxiety and depression. Now, the unexpected sequelae are really what I would say caught us off guard, especially earlier in 2020, when long COVID was just starting to be defined. And to date, I would say that the neurologic sequelae have truly been a surprise to many of us. And the lay press has done a great job of kind of summarizing the burden of a lot of these neurologic sequelae. And I would say the most common that we see are cognitive dysfunction, which has been colloquially referred to as brain fog, but also chronic fatigue, which many of us believe to be a variant of chronic fatigue syndrome, or also known as myalgic encephalomyelitis, which can occur after both infectious but also non-infectious illnesses. And lastly, dysautonomia has been very well defined at this point. And dysautonomia is essentially disruption of the component of the immune system, which regulates a lot of the kind of behind the scenes type of biologic functions, such as heart rate, blood pressure, temperature regulation. We're actually seeing a lot of overlap across all of these type of neurologic sequelae. So in addition to the neurologic issues, there have been complaints and disruptions across all the organ systems of the body. We're learning more and more that the GI tract is implicated in long COVID, and it can represent with an irritable bowel syndrome type presentation. We're also seeing disruption of dermatologic issues, as well as, unfortunately, thromboembolic disease. And again, I would put these later presentations as in this more unexpected category. And because of that, the science is still catching up at this point. So we can go to the next slide. I'm going to talk a little bit more about what we know about the epidemiology of long COVID. And I always like to start any talk about epidemiology, especially with long COVID, on the fact that all these studies, you'll see a wide range of reported prevalence, anywhere from 2% upwards of 70%. And from an epidemiologic perspective, it's always very important to consider who is being evaluated in a study, and what are your denominators, and what are your outcome measures. So having said all of that, I'll walk us through a little bit of the history of what we've known about long COVID. So when a lot of us were starting to care for patients with long COVID in 2020, really the only papers that were being reported were very biased cohort studies where we would see prevalence upwards of 70% sometimes. And the common characteristic of a lot of these cohort studies is they report, well, the case definition of long COVID is at least one symptom. And a lot of times the one symptom can be something like fatigue or muscle aches, or some of the symptoms that are, can be quite common after infection, and don't necessarily represent kind of the more severe, debilitating, or longitudinal long COVID that we now use as a case definition. So I like to highlight this study that was published in PLOS Medicine in the fall of last year. And I think this was one of the first large studies that looked at a very large sample size. So they did an electronic health record review of over 58 healthcare centers across the country, which included over 270,000 survivors in the US alone. And this study reported 37% prevalence of, again, at least one symptom at the 3 to 6 month range. Next slide, please. Around the same time, this paper also came out. And I like to highlight this manuscript because it was actually put together by long COVID survivors themselves. So this was a study that was a collaboration with several support groups of long COVID patients. And they did a survey conducted across their participants. And this included over 3,700 people suffering from long COVID. And they actually had very high rates of reported long COVID. So 86% reported this kind of relapsing pattern, which is now become very well known to occur with long COVID. 87% reported fatigue, and 45% reported a reduced ability to work. So here we're starting to see reports of how this actually could impact the workforce. Next slide, please. So then how about now? So now there's the summer of 2022, what do we know about the epidemiology of long COVID? The CDC put out this MMWR last month, which I think is actually a fairly well done EHR review. So they looked at national data from March of 2020 to November of 2021. And this included a 5-to-1 case to control study design. So they looked at over 350,000 case patients, which were defined as someone with a diagnosis of COVID within that time window, versus over 1.6 million controls who did not carry a diagnosis of COVID. And they further stratified their analysis based upon age. So they looked at a younger age category of 18 to 64, as well as a second category of 65 years and older. And interestingly, they did find very high rates, again, kind of on par with what we've seen from prior epidemiologic studies. But I think what's gotten a lot of media attention is this statistic where they're saying 1 in 5 adults over 18 who had COVID may present with a post-COVID complication, and that truly is a striking number. And the way they came to that conclusion was that they compared the outcome of post-COVID complication in the cases versus controls, and there was indeed a much higher rate of endorsement of a post-COVID complication in patients versus controls. So 38% across COVID patients versus 16% of controls. And this finding was even more robust in people who are over the age of 65. So I think this is a good recent publication that truly shows the burden of long COVID, especially in the United States. Next slide, please. I just want to briefly highlight some of the work that my team has been doing at NYP Columbia. So we put out a report last year that described the initial 1,200 patients who were hospitalized in the first surge in March of 2020. And our findings were consistent with what's been reported in other national cohorts. So at 6 months, we had 26% reporting cardiac and pulmonary symptoms, 24% with neuropsychiatric symptoms, and 21% with gastrointestinal symptoms. So again, this is coming from EHR data. Next slide, please. So then how about if we look at a smaller cohort with more granular data? And this has been an emphasis of what a lot of cohorts around the country are doing now, including the CFIC trial, which I'm a co-investigator at NYP Columbia. So the aims of our trial are to better characterize the different phenotypes of long COVID, which I've already described. But I think even more importantly than characterizing the definition of the phenotypes, it's really understanding the trajectory. So meaning when do these sequelae tend to occur? How long do they occur for? What are predictors for patients having persistent symptoms? And then what are the patterns of recovery? Is there relapse and remitting patterns? Do some people fully recover? So these are the questions that in a smaller cohort as opposed to larger EHR data, we have the ability to do based upon our survey work. So I'm going to present just a few slides just to give to highlight some salient points about long COVID we found within our study. So just briefly, our study, we conduct over 11 visits over the course of 2 years. We're actually extending this time period now because unfortunately, we are seeing many participants endorsing long COVID beyond the 2-year point. We collect survey data that includes both acute COVID symptomatology and severity, as well as sequelae at time points every 3 months after their initial infection. And we've also built a biorepository of blood and other biospecimens, which we're currently utilizing to study underlying mechanisms. And I'll talk a little bit more about that in the upcoming slides. So next slide, please. So what are we seeing in terms of the different phenotypes? So similar to what the other larger EHR studies have shown, we're seeing as upwards of 50% of participants reporting some form of neurologic long COVID at 3 to 6 months. Now, the question is, what is the severity and truly what type of neurologic sequelae are these patients endorsing, which I think can be lacking when you're looking at larger EHR data. So when you restrict our case definition of what phenotype of long COVID we're looking at to just neurocognitive, meaning excluding fatigue, only patients who are reporting difficulty carrying out tasks or difficulty carrying out work, the number goes down from 50% in the 50s to closer to 12 to 15%, which I think is interesting because this can be a marker of overall burden, especially if we're talking about return to work and the impact on the workforce. So I think that's an important point I wanted to highlight. And then how about non-neurologic sequelae? So we're seeing similar rates in our study that other cohorts are reporting. So in around the 30 to 40% range of people reporting cardiovascular, pulmonary, GI, and musculoskeletal complaints. Next slide, please. And I also just wanted to briefly emphasize that mental health sequelae is also unfortunately quite rampant. We took a look at the overlap of various mental health outcomes, so specifically anxiety, depression, insomnia, and PTSD. And within our CPIC cohort, we saw a great overlap when using the Pearson's correlation to identify our patients presented with more than one mental health outcome. And I just wanted to put this slide in here just to emphasize that not only is mental health sequelae syndemic with the cardiopulmonary and neurologic outcomes, but even within mental health outcomes themselves, there's a lot of overlap, unfortunately. So next slide, please. So now I'm going to change gears and talk about proposed mechanisms of long COVID. And I want to just give the caveat that this is truly a very novel area of science and research, and it's ongoing. But in the past year alone, there's been a lot of breakthroughs in better understanding what's causing long COVID. And I'm going to highlight some of them today. So next slide, please. So first, we'll start with the hypothesis of autoimmunity. So next slide, please. So in the acute phase of COVID, it's been very well established now that there is a flare-up of production of autoantibodies. Now, these autoantibodies, some of them are pre-existing in patients prior to COVID, and many of them are very non-specific and probably would be activated by other forms of critical illness or other viral infections. But to date, there have been a few, I think, very well done studies that have shown an increase in specific autoantibodies. And again, this is in the acute phase, so within the first few weeks of someone's COVID infection. So we've seen reported elevations in ANA and anti-SA and Rho, which are kind of non-specific markers that can be seen in lupus, scleroderma, or Sjogren's, or other autoimmune diseases. It's also been shown that autoantibodies against type 1 interferon have been elevated. And there's also been just overall broad production of autoantibodies. So the last study that I cite here by Wang et al. is a group from Yale that identified that there have been autoantibodies identified across almost all the different areas of the immune system, both innate and adaptive immunity, so that have activated cytokines, chemokines, complement, and other proteins. And we're actually working with this group to see if we can identify these same autoantibodies in our convalescent long COVID samples. So next slide. So how about long COVID specific autoantibodies? So some of the autoantibodies that we've all been curious about are the ones that have been previously reported in other conditions that have been similar to long COVID. So specifically for chronic fatigue syndrome, there's a body of literature that has shown disruptions in adrenergic and muscarinic acetylcholine autoantibodies. And a lot of this work is being validated now, again, in long COVID, because as I mentioned before, many of us do believe that some phenotypes of long COVID are a variant of chronic fatigue syndrome. And there have been some studies that have shown these G protein coupled receptors have been detected. So this is, again, an ongoing area of research. Now, the anti-ACE2 autoantibody has also been identified later in convalescence. So this is another potential target. And as Dr. Eckert mentioned, the ACE2 receptor is not only in the lungs, but also in other organ systems. So there is biologic plausibility that if there is an autoantibody directed towards the ACE2 receptor, this could be causing sequelae across many different organ systems. So next slide. So the next general category that I like to highlight is immune dysregulation. So we talked about autoantibodies. Now that's part of the adaptive immune system, but how about other areas of the immune system? So there have been many reports to date that have showed increase in inflammatory cytokines and other components of the immune system in long COVID patients versus controls. Now, I don't want to go into the details of this. I think we could get lost in the weeds here. And honestly, a lot of studies are showing different cytokines being elevated. So to date, there is not a single panel that we can give to help characterize long COVID. But I do think with time, as we get better case definitions, better understanding of phenotypes, and eventually better biomarkers, we will be able to better define the immune dysregulation that's happening. So next slide, please. Okay. Now, the last general category of long COVID mechanisms is viral persistence or reactivation. Now, the concept of viral persistence, this could mean that is the SARS-CoV-2 virus being harbored in areas of the body and causing ongoing inflammation and symptomatology. There have been some studies that have shown that people can harbor SARS-CoV-2 in the GI tract for several weeks, if not several months. And we're actively researching now if this could be potentially exacerbating the irritable bowel syndrome like phenotype that I previously described. And the other kind of similar related category of mechanisms would be reactivation of other viruses. So there was a manuscript that was published a few months ago in Cell that was one of the first to show any evidence of this. This has been something that a lot of us have considered would be reactivation of a virus such as Epstein-Barr virus, which has been linked with both chronic fatigue syndrome as well as fatigue after mononucleosis infection. And they did see that there was reactivation of a correlation between reactivation of EBV, at least early on, with development of long COVID. So that's another area of research that many of us are actively pursuing at this point. So then how about the care that we currently offer to long COVID patients? Now, you'll see there are many different models that are being used throughout the country and throughout the world, and they're constantly being adapted as we learn more about long COVID. So I can speak about what we do at NYP Columbia. So my practice, I follow a panel of around 30 very severe long COVID patients, the majority of them with neurologic sequelae such as brain fog, dysautonomia, or chronic fatigue. And I work with other specialists in the neurology and psychiatry departments to provide care. And so aside from that, there are also a myriad of other specialists, such as Dr. Eckert in pulmonology, as well as cardiologists that we work with. So I think overall, providing a multidisciplinary approach, I think is quite important for these patients, because in reality, there really is not one type of long COVID patient. Every long COVID patient is unique. It needs to be kind of triaged on how to best approach them. So I think that comprehensive care with specialists across the various practices is important, but also what can we do right now for patients? So some of the best treatments that we can give are actually quite simple lifestyle modifications that include dietary changes or identifying foods that can possibly trigger exacerbations. We know from treating dysautonomia and such as POTS syndrome that you can do things that can prevent exacerbation of symptoms. And we've seen patients with great reported benefit from wearing compression stockings, and also making sure that they stay hydrated and have adequate salt intake. And there are other pharmacologic medicines that can be used for both dysautonomia and also insomnia that many patients are reporting improvement with. And then lastly, I like to mention the other services such as rehab and mental health services. I think they're essential for providing comprehensive care. So really, this is where you have to kind of identify the needs of your patient and try to link them with either PM&R for musculoskeletal rehabilitation or pulmonology or cardiovascular rehab. So that's an overview of kind of the state of comprehensive care. And next slide. And lastly, I'd like to leave with just some clinical resources in case anyone from the audience wants to learn more about the various approaches to long COVID. So many different groups have released treatment guidelines at this point. So the CDC, IDSA, AAPMR, the AMA, WHO, and even UpToDate has fairly comprehensive guidance for caring for long COVID patients. So I wanted to put that out there in case anyone wants to refer to those. And then lastly, for anyone who's working with long COVID patients, I find it very helpful to provide validation and also just emotional support. It's one of the hallmarks of any long COVID visit. And I also like to let people know that there are many support groups that exist, and they're actually quite excellent. And I know many patients feel very empowered by being connected with other people who are suffering from, unfortunately, the same type of condition. So I wanted to leave it with that, and looking forward to discussing further.
Awesome. Thank you very much, Dr. Pepper. That was a terrific talk, and very much appreciate your insights on long COVID. So I'm going to now transition it over to Lara, and she's going to give us a perspective from MEMIC and from her position in terms of what she's seeing, on the front lines with our injured workers.
Great, thanks, Ben, and thanks, Christina and Lawrence. That a lot of what I'm going to talk about as I started thinking about this is it's hard to come up with just a few things that are impactful in workers' compensation. And based on everything that you've said, every case is unique. And so we always look at cases in our space, what's going on with that particular injured worker. But as I was thinking about this and as I was talking with some of our claims partners and our case managers that work with these injured workers who have experienced COVID or long COVID, there were about 5 themes that just kept recurring in the conversations that I had with folks. And you've answered some of those questions here. So I suspect if there are some folks from the workers' compensation space on this webinar, some of the things that I will talk about are things that you talk about in claims and in roundtables and that type of stuff. And I have these sort of like 5 themes. They're in no particular order. But I'll start with the first one, and it's not so much specifically related to long COVID, but certainly becomes important in our world if a claim becomes a long COVID claim, and that's regarding the initial compensability of a claim. And so really one of the things that my claim partners talk to me about a lot is how do we determine if the COVID exposure is resulting, arising out of and in the course of employment, or if it's just a result of just living in a world where COVID exists and just functioning, in your day-to-day life. And so unless in thinking about states that have presumptions and where those rules still exist or certain classes of employees, how long would somebody need to be exposed in the workplace in order for us to say, yes, this definitely happened in the workplace and not because you were traveling on the train to work that day or something like that. And what kind of symptoms would the injured worker need to be exposed to in the workplace that we could say with some certainty, yes, this did happen as a result of being at work, as opposed to traveling in on the train or a family event the day before. So that's one of the topics that continues to recur, and it becomes particularly important in long COVID because if we accept the compensability of that claim, we have all of these things that you've talked about that could be happening with that injured worker. The second one is sort of 2 parts, and that's really related to a typical recovery. So we know that there are these groups of people that have a positive COVID test. They maybe stay out of work for a little bit because they need to, isolate or quarantine, and then then it's time to maybe go back to work, but symptoms continue to prevent them from returning to work. And how do we tease out what symptoms are actually occurring from the COVID diagnosis or are the result of something else? Maybe it could be dissatisfaction with work or with coworkers or so what, how do we really identify those individuals who are just not recovering and really what is going on there? And then the other sort of bucket in this typical recovery is after positive COVID exposure, and that expected recovery occurs and someone goes back to their normal functioning and daily activities, but then weeks or months later, symptoms start to occur that prevent them from being able to function in the workplace. Can that be related back to the initial COVID exposure that we already deemed work-related? So that's another challenge that we have in really understanding some of these things. And then when we think about those injured workers who did have a much more complicated or severe case, maybe it's the post-intensive care syndrome. Once they're out of that really severe state, how do we educate them on what to expect? And I think, Dr. Papara, you explained some of this, but how should, if I'm a nurse case manager or if I'm a claim handler and working with my injured worker, what can we say to them to help set some expectations? Understanding that every case is unique, and the facts of that case will certainly determine some of these answers. I think at this point, it's no longer a question, is it just tincture of time? But are there medications that we should see, or maybe we should not see? If it is a work-related compensable claim, we're paying for those medications. Are those really related to COVID or something else? Some of the other questions that come up that you've already answered, is conditioning recommended? So, whether it's physical therapy or some type of light exercise to help recondition. What is best for these individuals? Support to manage anxiety or fears that come with that. What is there any best practices there? Or any other supportive treatment or education that we can provide to really help this injured worker on the path to recovery, because that ultimately is our goal, is to help this injured worker on the path to their recovery and back to a functional lifestyle, and ideally back to some level of meaningful work. Let's see, number 4 on my list here of things that came up was in respect to whether, if the severity of COVID that the individual experienced results in their inability to go back to the type of work that they were doing. Maybe they were more heavy labor, or their job required them to do a lot more standing and walking, and they've had some pulmonary complications. What should we see for reasonable restrictions or limitations that would help us in determining if vocational rehab is appropriate at a certain period of time to help that injured worker get back to meaningful work? And then sort of, this is probably all of these things combined, but the final theme that continues to come up for us is really challenging and answering these questions that I've just laid out, and finding medical experts who can guide us or help us to answer the questions that we have as these cases are presented to us. So those are some of the challenges that we experience.
Those are all excellent, Lara, and a perfect segue to our session, our Q&A. So what I can do is I'm going to navigate between some of the questions that we've gotten from our audience. So clearly we've stimulated a lot of conversation here. The question that we've gotten is sort of the theme that Lara mentioned as number 5 seems to be the most common theme, which is very interesting, but it's the idea of how do you find someone to treat long COVID, right? I actually got someone who texted me on my cell phone, and they want to see you in the office, Dr. Purpura. So you're going to be busy after this webinar. You're going to have at least 70 participants who seem to have long COVID. So I'll open up to both of you. What is the best resource for someone to seek care from a provider of repute like yourselves for long COVID, other than working through BICMD?
I could take a first step at this. So this is actually a topic that fortunately I've seen improve over the past year and a half. Now, if you would have asked this question in 2020 in the fall, there truly were no resources then. And not only was there a paucity of resources, there was rampant stigmatization of these patients. They were reporting to providers and were actually not being heard or not believed. So I've seen this get a lot better, and I think more providers are being educated on what long COVID is and how it can present. So the ultimate goal is, I think that this falls within primary care, and I think we need to start providing education and to putting the information out and disseminating it to allow primary care providers to be able to at least be the gatekeeper for a lot of these patients who are presenting with these complications. I'm on panels with both New York City and New York State, and we put out a Dear Provider letter a few weeks ago to all the providers in New York City, educating on this topic. And I think it's these type of efforts that are essential, because that's truly the first line, is I think on the primary care level. And then what follows there? Then I as I mentioned in my slide, I think these comprehensive COVID clinics are incredibly useful. From a patient care perspective, just having specialists who are truly dedicated to it and really up to date on diagnostics and treatment, I think is very important. But the question is, how do we get patients connected to these clinics. And unfortunately, the wait list is incredibly long for all the clinics, even my own. So it's a question of resources too. So my long-winded answer is that things are getting better in terms of linkage to care, but there's a long way to go. And a lot of that is, I think, going to depend on just how much resources we can put in to this issue, and also education, what I'd say the two most important tenets.
Perfect. Dr. Eckhart, anything to add to that?
Yeah, I definitely agree with Dr. Purpura. I think starting with your primary care doctor is key. And then, as Lara mentioned, every case of long COVID is different. So depending on the symptoms that you're dealing with, your primary care provider can then refer you into the appropriate specialist. So, if you're having persistent cough or shortness of breath, then you want to come see a pulmonologist. If you're having brain fog, confusion, you want to see a neurologist. So I think the key is to start with the primary care physicians. I think they're probably the most accessible, and then they can refer you in to the appropriate specialist to help you develop sort of a team of doctors who can help you manage those symptoms.
Perfect. And this is a question for Lara. So the question is, with an increasing number of home tests and, increasing number of infections still in the community, do you think it makes sense for every employee to report their COVID positivity to their employer, thinking in terms of workers' comp and insurance for short-term and long-term disability?
Well, I think I'm going to speak more broadly just as a human being. I think it's important if you're exposing yourself, you have a positive COVID test and you are maybe choosing not to isolate or follow some of the recommendations, then I think it's important to make sure that the people around you know that you have had a positive COVID test. I think when it comes to whether it's whether you report it as a workers' compensation claim, you really have to think about if you would have been exposed to COVID in the workplace at first, and I think maybe just use some critical thinking there. If you were at a concert over the weekend and on Sunday you work a Monday through Friday job, and on Sunday you started to experience a sore throat, or maybe the next Saturday or something. That may not be related to work, especially if you're not exposed to a lot of individuals that potentially had COVID. Now, if you work in a place where there is a known COVID exposure and your symptoms occur as a result of that, then that might be a reasonable report to your employer. So there's not one right answer there. I think making sure that you are reporting your positive COVID test to your medical provider is important, because that's the first place where you're going to have that documentation that you've had a positive COVID test, and potentially, I'm not up on the current science on all the treatments, but potentially maybe if you need treatment based on who you are and your medical conditions.
Perfect.
I'm not sure if I answered that question fully. I think there's not one right answer.
Yeah, no, exactly. This is all an area of evolving science, and it's a little bit in the gray, and that's why we're having the webinar. And speaking of in the gray, this is a question for Dr. Eckhart, and knowing that this is a question that she's fielded for us a few times at Best in Class, what is, or do you have any guidance around thinking of how, whether a worker got COVID at work versus, out somewhere in the community? And that was one of the themes that Lara touched upon.
Yeah, that's we've certainly encountered that in some of the BICMD cases. It's a really difficult question to answer, especially in the absence of true sort of contact tracing, which can only really be done through a Department of Health. It's really difficult to prove that somebody got COVID in the workplace. Even if there's somebody in the workplace who has COVID and you later test positive, it's really difficult to establish the temporal relationship between the two infections unless both parties are, testing every day, and then you can sort of establish that temporal relationship. So in the absence of really intensive contact tracing, I think it's really difficult to definitively say this person got COVID at work, which has sort of been, our response to some of these cases through BICMD. And I think I would, stand by that, it's very difficult to prove when and where somebody got their infection.
Great. And this is a question for you, Dr. Pepper. So, look, we know that our understanding of long COVID is evolving, but sometimes you have to live in the gray. And you can say, we sort of think that there is more of a likelihood that someone has X, right? Using the best of our knowledge and the best of our judgment. Is there a way right now to say that someone has long COVID versus some of the other symptoms like chronic fatigue or pre-existing conditions? Because that really gets to the heart of it for a lot of our clients, is like, they just want to know, is this long COVID?
Yeah, that's a fantastic question. And I am optimistic that as we learn more about the various phenotypes and a lot of the biomarker type of information that I presented, someday we hope that there will be a way to do that. But the reality is right now, honestly, the way we approach long COVID is the way we approach other diagnoses of exclusion, right? So when you come to see myself in clinic or a lot of other long COVID clinics, the first things we send for hemoglobin A1Cs to make sure someone's doesn't have an undiagnosed diabetes. We send for CBCs to make sure the patient doesn't have underlying anemia, for example, that could be causing fatigue. So part of the workup for long COVID is ruling out the more common presentations that can mimic these broad types of long COVID. So that's the first thing that we do. So that's a very non-targeted approach. And I know it's not the answer that a lot of us want, but that's really what's happening right now. Now, I've presented some of the cytokine information. We are setting these type of panels for people, and certainly in some patients, I have found it to be very helpful to identify various cytokines that have been elevated, especially if they're kind of fitting the neurologic phenotypes. I can also think of other patients where I've identified unmasking of autoimmunity with very high ANA titers. So that also, I think, would provide more laboratory evidence that there is a biologic manifestation of long COVID. So that's kind of the tip of the iceberg type of stuff that we're doing. But I do think it's going to get more granular and more specific in the upcoming months, because my study is just one of hundreds, if not thousands, I bet they're happening all throughout the world, where everyone is trying to figure out what are the biomarkers that we can use to both diagnose, but also monitor treatment to long COVID. And also could potentially be turned into potential monoclonal antibody treatments or other immunologic treatments. So I do think we're going to see massive advancements of science in the next 6 to 12 months.
That's actually quite optimistic, because look, our treatment of COVID itself has evolved. We very, very quickly, we, created a vaccine very quickly, and then Paxlovid came on the scene, quite quickly. And so it's hopeful to think and to know that in the upcoming months, 6 months, a year, we can definitively diagnose, hopefully, long COVID and potentially treat it. So this is a question from one of our participants. And so the question is, besides the brain fog associated with long COVID, what are some of the other neuropsych conditions, and do you have a sense of their prevalence? So, and they ask specifically about post-COVID psychosis.
I am speaking as not a neurologist, but I think the most predominant neuropsychiatric symptoms after infection are depression, anxiety, and sometimes post-traumatic stress disorder, particularly among patients with severe infection who were hospitalized. The prevalence, as Dr. Purpura mentioned, is quite variable. I've seen numbers anywhere from 20 to 50% prevalence after 4 weeks after the initial infection. Overt psychosis is less frequently observed. Certainly somebody with severe depression could develop overt psychosis, but that is not one of the more well-described neuropsychiatric symptoms of long COVID. And if somebody did develop overt psychosis, I would want to search for sort of other potential causes, not to say that it can't be caused by long COVID, but again, it's always a diagnosis of exclusion. So I'd want to rule out other potential causes first.
Perfect. And we seem to have lost Dr. Purpura, likely connection issues. This is a question for you, Lara. Do you have a sense of how long people are, staying out of work, or how long it's taking them to return to work when they have a diagnosis of long COVID, or is it still so early that you don't have a sense of that?
Yeah, well, from our experience, fortunately, I don't think we have enough injured workers to say that we have a true duration of disability for somebody that has long COVID. I think it really, and it also really depends on the severity of their COVID infection. How long were they in the ICU? Did they need dialysis? So, some people are recovering to a more functional level. Others are still, dealing with lots of post-COVID sequela. So not yet, I think. Probably sort of the theme here. Still a lot to learn.
Perfect. And I will direct that similar type of theme of question to Dr. Purpura. Glad to have you back, Dr. Purpura. So the question was, I asked Lara how long it's taking people to return to work after being diagnosed with long COVID. And so in your cohort, are you seeing people fully recover, or, be as close to functional with long COVID? And do you have a sense of how long that's taking?
Yeah, so fortunately, I'm happy to say that the majority of patients do improve over time. Just anecdotally from both my clinic, but also from our cohort, I would say that the average duration of severe symptomatology is 3 to 6 months, and we tend to see dramatic improvement by 1 year in the majority of patients. Now, as I highlighted it in my presentation, really, when you use a case definition of endorsing just one symptom of COVID, long COVID, you're going to see very high rates, and you'll see this persist over time. But if you try to get more granular and you start asking, what is the impact on daily living, or what's the impact on carrying out tasks at home, that's where you can really start to see that I don't think the burden is as high as a lot of these epidemiologic reports are showing. And if I had to give a guess on what percentage of people are actually having persistent debilitating symptoms over 1 year, I think it's honestly well less than 1%. But we certainly need more official reports to validate that. But that's what I've been seeing, at least anecdotally. And I use this when I counsel my patients, because I think it is quite optimistic. Now, on the flip side, there are a very small subset of patients where, unfortunately, I've seen them still on disability well over 1 year out, some of them pushing 2 years out, that are on long-term disability. And I am entirely convinced that it is true devastating neurologic long COVID. So those cases are out there. They are happening, unfortunately, but in some, the vast majority of people are improving.
I think that is very helpful. And, I think that really hits home on one of your themes, Lara, where it's the idea that, it is possible where a year or two out, people have, long-term disability, but, that number is 1%, right? Or close to it in terms of people who are having disabling, out of work, long COVID type symptoms. And it's sort of, important to, take into account all of the things and rule out all the potential medical comorbidities. I know we're coming up in the hour, so I'm gonna just do 2 more questions, okay? If you guys have a few more minutes. So one of the questions that came across the chat was, are there, and with our clients having to pay for treatments of long COVID and things like that. So I'm an orthopedic surgeon. I would encourage an insurer to pay for platelet-rich plasma, right? And I think that that's really good, even though it's not covered by insurance. I think it works. For long COVID, is there a PRP equivalent, right? Where, you say, look, I think that it's worth covering the expense of this treatment or this drug, because it actually has been shown to have good impact, even though there's not a lot of published literature on it right now.
I would say, I think it depends again on the symptoms. In general, I think at this point, treatments that are sort of widely applicable are things like physical therapy to address sort of joint and muscle pain, and pulmonary rehabilitation to address people with persistent respiratory symptoms to help strengthen their respiratory muscles. And then psychological counseling for people who have those sort of neuropsychiatric symptoms like anxiety or depression. I think those are all sort of widely applicable treatments that should be covered. And then with respect to more specific treatments, I think it depends again on your complication and specifically the presentation of that complication. So I can speak mostly related to lung disease, but when people have persistent symptoms after COVID, we pursue extensive testing through imaging and pulmonary function testing, and can start anything from steroids to inhalers to potentially antifibrotic therapies, depending on their presentation. And so I think with respect to the more specific medical treatments, the jury is still out, and the clinical trials are ongoing to determine which medical therapies are most effective in this case. But at the moment, I think some of those more generally targeted therapies towards physical rehabilitation and neurocognitive rehabilitation should certainly be covered.
Great. Great. What I didn't hear there was vitamin B12 infusions.
Jury's still out on that one.
Very good. All right. So, and then the last question, nice soft landing for you guys, because even if it was an orthopedic surgeon, I think I may know the answer to this. For people who have long COVID, are you seeing that they're testing positive for COVID still, even in the long term?
So in some patients, you can have persistent viremia. We tend to see that more so in immunocompromised patients. So we care for a lot of transplant patients at NYP, and I have seen persistent viremia. But the thought is that it's actually not the colonization of the respiratory tract that's resulting in long COVID. So I would say that testing for the SARS-CoV-2 virus really doesn't have any utility in diagnosing long COVID. But I did also, the caveat is I did also mention that in some patients we're seeing sustained GI carriage, and we think this may present with IBS in some patients. So is there a hypothesized role of potentially testing in other reservoir sites throughout the body? Possibly, but certainly not respiratory tract. And if anything, if it's due to viral activity, a lot of us suspect more so it's due to potentially reactivation of other viruses like EBV, as I mentioned, and not specifically SARS-CoV-2 anymore.
Wow, the answer to that was a lot more involved than I thought. I would have failed that test. All right, very good. Well, this has been a great hour. I've learned so much about long COVID manifestations. I really want to thank Lara for your time tonight. I want to thank Memic for the sponsorship. Dr. Eckhart, I want to thank you for your time, and Dr. Perper, I thank you. We will triage some of the questions that we didn't get a chance to answer in the hour, triage them to you guys just to make sure that our audience gets all their questions answered. So thank you all very much.